Hello and welcome. I'm Michael Thorpe. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for today's educational activity. It's entitled Laying to Rest Challenges in Managing Excessive Daytime Sleepiness and Augmented Reality Experience. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. This activity is supported by an educational grant from Jazz Pharmaceuticals. Today's CME CE activity is also eligible for ABIM mock points. So make sure you engage in today's event. Answer polling questions, submit questions, and provide your feedback. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your mock points. I am Michael Thorpe, Professor of Neurology at Albert Einstein College of Medicine and the Director of the Sleep-Wake Disorder Center, Department of Neurology at Montefiore Medical Center in the Bronx, New York. I'm also President of New York State Society of Sleep Medicine and past President of the Sleep Section of the Academy of Neurology. I would like to welcome my colleague, Richard Bogan. Rick is President of Bogan Sleep Consultants, Medical Officer of SleepMed, and Director of SleepMed of South Carolina. He is also the Associate Clinical Professor at the University of South Carolina School of Medicine in Columbia, South Carolina, and Associate Clinical Professor at the Medical University of South Carolina in Charleston, South Carolina. Let me review our learning objectives. Our first learning objective is to recognize the burden of excessive daytime sleepiness in patients with obstructive sleep apnea syndrome and narcolepsy. Our second learning objective is to apply the science of sleep to novel treatments for excessive daytime sleepiness so that we can optimize treatment selection. And our final learning objective is to integrate efficacy and safety data into treatment decisions for excessive sleepiness in patients with OSA or narcolepsy so that we can improve quality of life and function. So, Rick, can you give us an overview of excessive daytime sleepiness in OSA and narcolepsy?
Certainly. I'm going to start at the bottom and work my way up. And I have to tell you, I heard a little bit of Carolina in there when you introduced me. So I must be having some influence. So I'm going to start with the bottom because all the patients with narcolepsy are sleepy. I mean, that's what they have. And of course, they have REM dissociative symptoms as well. But when you look at the data, the thing that's most disruptive to the patients, I mean, 88%, and to the physicians, 92%. So they are profoundly sleepy, and we know the challenges in terms of trying to treat these individuals and relieve the effect of the excessive sleepiness. The OSA group is an interesting group because it depends on the cohort that you're looking at, and you know what group you're studying. Because some of the patients with sleep apnea who present to us are not sleepy, but most of them are sleepy, and it's one of the most common medical problems to cause excessive daytime sleepiness. And of course, we put them on CPAP, and when we put them on CPAP and relieve the obstruction, we do our downloads of the AHIs are great, but many of the patients are still sleepy. And I would argue with the 5 to 10%, I think that's actually low, but many of the patients still have excessive sleepiness, and we're going to explore that.
Right, so let's have an audience response question. So I'd like to ask you, our audience, to get involved here. Now, you should see an audience response question on your screen. Now, you can vote now. The question is, how confident are you in developing treatment plans for patients with obstructive sleep apnea or narcolepsy that reduce the burden of excessive sleepiness? The answer options are A, extremely confident, B, confident, C, somewhat confident, and D, not at all confident. I'll review the results with you a little bit later in the program. Okay, let's have an animated tour at this point. So Let's look at the first animation on the extent to which excessive daytime sleepiness impacts several systems of the human body. Rick, can you give us an animated tour here?
The impact of EDS is extensive. In general, it results in fatigue, spontaneous sleep onset, slow reaction times, frequent napping, and even automatic activity. Specifically, as we see here, EDS exacerbates medical conditions such as hypertension, diabetes, obesity, and cardiovascular disease. Sleep homeostasis has a huge effect in these areas and also impacts immunity. EDS also impacts various psychiatric conditions, including depression, anxiety, coping skills, and poor attention, for example, ADD. Here it is evident that EDS likewise affects cognitive dysfunction, motivation, social and family interaction, as well as workplace productivity. And finally, we see here that the impact of EDS also results in neuronal loss, resulting in global and regional atrophy.
Okay, so in the animation, we saw how excessive daytime sleepiness impacts various psychiatric disorders. But let's go into that in a little bit more detail. You can see in the slide here that in patients who are excessively sleepy, as shown in the orange bar, the prevalence of depression is much higher than those that are not sleepy. So there are higher rates of depression, and this is seen in a number of different measures, including MCS and SF indicators. So employees with obstructive sleep apnea syndrome or excessive sleepiness are twice as likely to be involved in occupational incidents. And you can see some of the problems illustrated here on the slide. You know, people complain about having brain fog, memory problems, impaired critical thinking, falling asleep throughout the day, poor job performance, strain on relationships, worsened quality of life, increased risk of accidents while driving. Okay, so let's take a look at another animation. So Rick, I wonder if you could tell us about how neurotransmitters involved in the sleep-wake cycle and tell us about their anatomical location so we can better understand how treatments are selectively targeted.
Let's take a look at the brain regions promoting sleep and wakefulness and the neurotransmitters involved. Wake-promoting pathways are found in the basal forebrain, from which acetylcholine projects, the tuberomammillary nucleus, housing histamine, the ventral tegmental area, housing dopamine, the dorsal and median raphe, housing serotonin, the locus coeruleus, housing norepinephrine, and the orexin neurons located predominantly in the lateral hypothalamus. Acetylcholine neurons in general are associated with cortical arousal and play an important role in REM sleep. High dopamine tone promotes wakefulness while low dopamine tone promotes sleep. Norepinephrine is one of the main neurotransmitters involved in arousal, and it is important in maintaining normal sleep states. Serotonin promotes wakefulness via the raphe neurons that are active during wakefulness. Serotonin precursors and reuptake inhibitors promote wakefulness. Histamine neurons promote arousal. However, lesions of the tuberomammillary nucleus have little effect on wakefulness. Orexin levels are high during wake. Orexins promote wake and suppress REM sleep. The thalamus is an important relay to the cortex. An important teaching lesson here is that lesions of the posterior or caudal hypothalamus and the rostral brainstem midbrain can cause chronic sleepiness, while lesions of the anterior hypothalamus cause insomnia.
Good, thank you, Rick. Now I'd like to ask our audience another polling question. And the question is, how often do you consider mechanism of action when making treatment decisions for excessive sleepiness in narcolepsy or sleep apnea? So A, not at all, 0% of time. B, 1 to 25%. C, 26 to 50% of time. D, 51 to 75%. And E, 76 to 100% of time. Again, I'll share the results of this poll with you later in the program. Please make a choice. Let's look at mechanisms of actions of a number of agents that are used to manage excessive daytime sleepiness and see if we can improve everyone's knowledge of mechanism of action of various wake-promoting agents. Now, if we look at the traditional stimulants, the methylphenidates and the dextroamphetamines, the amphetamine derivatives, these have high affinity, but not non-selective for the dopamine transporter, the norepinephrine transporter, and the serotonin transporter. The wake-promoting agents, such as modafinil and armodafinil, have low affinity, but are dopamine transporter selective. Solriamfetol, which we'll be talking about more later in the program, has low affinity, but is selective for the dopamine transporter and the norepinephrine transporter. Pitolisant is quite different. It has high affinity, but it's selective for the histamine 3 receptor, and it's an inverse agonist of that receptor. Sodium oxybate has high affinity for the GABA B receptor. Okay, so let's move on to treatment decision making for excessive sleepiness in patients with sleep apnea or narcolepsy. So to start off, we'll have another polling question. So in CPAP compliant patients with obstructive sleep apnea syndrome who experience persistent excessive sleepiness, which agent are you likely to first use to treat this persistent sleepiness? Your options are A, the amphetamines, B, modafinil, C, pitolisant, D, solriamfetol, and E, you're just not sure. So please vote, and again, we'll see the results a little later. Now, Rick, let's move on to the FDA approved treatments for excessive daytime sleepiness. Can you review these for us?
Certainly, yeah. Thank you, Michael. As you well know, interesting looking at these neurotransmitters and looking at these selective aspects of these different medications. You can see the FDA approved ones based on pivotal trial data, modafinil, armodafinil, as you recall, those are low affinity selective dopamine transporter. They bind to the dopamine transporter. And of course, sodium oxybate has been approved by the FDA to treat narcolepsy with cataplexy or narcolepsy with excessive daytime sleepiness in patients 7 years and older now. It used to be 18 and older, but now 7 years and older. Solriamfetol is a new drug, and we'll explore it some more later on, but it has been approved to treat excessive sleepiness in both narcolepsy and in obstructive sleep apnea patients who are on treatment, on CPAP, and still have excessive daytime sleepiness. Pitolisant was studied in Europe, and we have some of that pivotal trial data, but is approved to treat excessive sleepiness in narcolepsy patients. So I think we actually have a chance to sort of look at this animation again and to see how these traditional and selective stimulants exert their effects on the sleep-wake cycle. And as I mentioned, stimulants are used to treat excessive sleepiness. Didn't spend much time on it. The stimulants, as I mentioned, are actually used for attention deficit problems, but we know that they do help with excessive sleepiness, and many times they are utilized. Traditional stimulants such as amphetamines are often used but are not FDA approved for EDS. Selective stimulants such as modafinil and armodafinil are FDA approved for treating residual daytime sleepiness. So let's look at how these work in this animation.
Traditional stimulants, for example amphetamines, are non-selective for the dopamine transporter, or DAT, norepinephrine transporter, or NET, and serotonin transporter, or SERT. Amphetamines also block monoamine oxidase, which prevents the breakdown of amphetamine. Dopamine and norepinephrine are released from presynaptic nerve terminals into the synaptic cleft to be captured by receptors on the postsynaptic neurons. Traditional stimulants, such as amphetamines, block the reuptake of dopamine and norepinephrine. Amphetamines can cause an efflux of these neurotransmitters, producing very high levels of dopamine and norepinephrine, which may contribute to their addictive and sympathomimetic effects. On the other hand, selective stimulants such as modafinil and armodafinil selectively target the dopamine transporter. Dopamine molecules, as we see here in yellow, are released into the synaptic cleft, where some of them bind to postsynaptic receptors, as we see here in red. Most of the dopamine in the synaptic cleft is recaptured by presynaptic nerve terminal via the dopamine reuptake transporter, or dopamine transporter. Drugs that selectively block the dopamine transporter include modafinil and armodafinil.
Well, thank you, Rick. Well, we're keeping you, our audience, busy tonight, so we have another question for you. Which of the following is best suited for a 31-year-old patient with excessive sleepiness associated with narcolepsy who's currently taking oral contraceptives? Is the best suited medication A, modafinil, B, modafinil, C, pitolisant, D, solriamfetol, or E, you just don't know? Okay, so we'll have the answers to that a little bit later. Okay, so let's now look a bit more at some of the newer wake-promoting medications and modafinil and armodafinil. These have been studied, as Rick mentioned, in both excessive daytime sleepiness and narcolepsy and obstructive sleep apnea syndrome. This is some of the data from obstructive sleep apnea syndrome studies, meta-analysis of those studies. And you can see that there is a significant improvement in the Epworth sleepiness score with both modafinil and armodafinil. And also, if you look at that objective test of sleepiness, the maintenance or wakefulness test, not a subjective test like the Epworth sleepiness score, but the objective MWT, you can see again that there are significant positive changes in terms of the MWT sleep latency. So let's talk a little bit about safety of these medications. The most common adverse events seen with these medications are headache, nausea, nervousness, rhinitis for some reason, some GI problems, anxiety, dizziness, and sleep disturbance. These are fairly typical side effects that we tend to see in wake-promoting medications because they increase arousal and increase wakefulness. Very often these are common side effects. However, with the modafinil and armodafinil, there are some other side effects which are not so common. And one is rashes. And there can be very serious rashes associated with the modafinils. Even Stevens-Johnson syndrome has been reported with the modafinils. And also, the other thing is that they may decrease the effectiveness of hormonal contraceptive agents. They increase ethinyl estradiol, and so they interfere with the efficacy of those contraceptive agents. And again, as many of these medications that increase arousal and alertness, there are changes in heart rate and diastolic and systolic blood pressure, which can also occur with this medication. Okay, so Rick, we know that stimulants are used to, the traditional stimulants are used to address excessive daytime sleepiness. Not all of them are approved. What are some of the safety outcomes that have been seen with traditional stimulants?
Yeah, you know, you saw on the simulation the fact that we get this dopamine release and then the effect on the transporter. So we get this effect in terms of wakefulness promoting. These drugs, these Schedule II drugs, do actually stimulate the wakefulness circuits to keep us more awake. However, and most of us know, one of the big problems is tolerance. These individuals develop tolerance, so they need higher doses to achieve the effect. And of course, the dopamine effects can produce euphoria in some of these individuals. So that increases the abuse liability as the individuals take more and more of the medication to try to get that effect. So when you begin to look at the data, high dose stimulants, greater than 120%, induced psychosis and psychiatric hospitalizations. And because of the sympathomimetic effect, we can see tachyarrhythmias, changes in heart rate, blood pressure, anorexia. So these are real problems with these particular medications. That doesn't say that they're not effective. They are, but tolerance, rebound, when the drug wears off, the patients crash and get more sleepy, and withdrawal symptoms are issues. And when you look at the data in 2016, the number of individuals who actually said they misused the drug, I mean, it's a really important. At one point, that's all we have. But now we have modafinil, armodafinil, and of course we have solriamfetol available and pitolisant in narcolepsy and oxybate. So we now have newer drugs that are more targeted and fortunately appear to have less tolerance.
So Rick, why don't you tell us about some of these new and novel and emerging therapies for excessive?
Certainly. Well, the pitolisant, as you pointed out earlier, is an H3 receptor antagonist, inverse agonist. So I think of H3, and we'll get to see this more later on, but H3 is a governor for histamine, and histamine is a very important neurotransmitter that promotes wakefulness. And it has been evaluated and studied, and there are pivotal trials that show that this drug does work with excessive sleepiness in narcolepsy patients. Solriamfetol was studied both in obstructive sleep apnea patients, and interestingly, in the study design, it looked at patients who were on CPAP as well as patients who were not using their CPAP who were sleepy. And I thought this was valuable because it gave us a chance to look at safety as well as efficacy in those individuals. Now, solriamfetol does not treat sleep apnea. It treats the sleepiness. So it's important for us to reduce medical risk. But importantly, it is a dopamine norepinephrine reuptake inhibitor. It's highly selective for that receptor and has been approved by the FDA. And we'll get a chance to look at more of that data later on. JZP-258 is a low sodium oxybate formulation. Remember, oxybate, sodium oxybate, when you acidify it, becomes gamma hydroxybutyrate, and gamma hydroxybutyrate appears to be a GABA B receptor modulator. So it inhibits certain of the awake circuits, particularly dopamine and norepinephrine, most likely based on animal studies. So it I tell my patients, it's kind of like turning the lights off. In other words, you go to sleep, and then when it wears off, the lights come on brighter. So the patients tell us when they respond that they wake up more easily and they are more alert during the day. And of course, it does help with the REM dissociative symptoms, particularly at this point, cataplexy, and has been studied in the pediatric population, so age 7 and above. The JZP-258 is a different cation, so there is a 92% reduction in the sodium intake. So if you take sodium oxybate, get a fairly high sodium load, 1.6 grams of sodium when you're on 6 grams. So this is a low sodium preparation, and we'll get to see the data on the efficacy in just a moment. Of course, there is some study of a long-acting preparation. It's sort of a suspension with a modified release, and this has been studied and is now, that study has been completed, and the data will be submitted to the FDA for their consideration. Once a night dosing of sodium oxybate.
Good, thank you, Rick. And now we've covered, and Rick, you've also covered a lot of the material that dealt with the questions that we asked previously. So we're going to come back now and revisit those questions and see how you do now with them. So let's do the first one. In CPAP compliant patients with sleep apnea who experience persistent excessive sleepiness, which agent are you likely to use first to treat this persistent sleepiness? A, amphetamines, B, armodafinil, C, pitolisant, D, solriamfetol, or E, you're just not sure. Okay, so here we have the results, and I see that the results have changed after our presentations, Rick. So we find that less people are picking amphetamines, which makes a lot of sense, don't you think, Rick? And because those are more likely to have cardiovascular consequences. And then we have the armodafinil is more likely. It has a lower potential for adverse effects. Pitolisant, not so many people picking that, even though it has pretty good cardiovascular pattern in people with obstructive sleep apnea syndrome. But significant number now realize that solriamfetol is an agent that can be used for excessive sleepiness and sleep apnea. And
Michael, we have to remember that, of course, pitolisant is not approved by the FDA for OSA.
Or sleep apnea, that's right, of course. Yeah. And it's good to see. Look how many people, Rick, have changed from being not sure about which agent to having a much better idea about what they should be using. Okay, so let's move on and let's look at another animation. So Rick, can you tell us about Solriamfetol in a little bit more detail as a novel therapy for excessive sleepiness in both narcolepsy and sleep apnea? Explain to us how it works.
Solriamfetol is the first and only dual-acting dopamine and norepinephrine reuptake inhibitor approved by the FDA that is specifically indicated to improve wakefulness in adults with excessive daytime sleepiness associated with narcolepsy or obstructive sleep apnea. The reuptake of dopamine and norepinephrine is blocked at dopamine transporter and the norepinephrine transporter. As we see in these dopamine and norepinephrine synapses, both the dopamine transporter and the norepinephrine transporter draw their respective neurotransmitters back into the presynaptic terminal, where it can be repackaged into vesicles. So what is the clinical impact of this different mechanism of action? Drugs that block both the dopamine transporter and the norepinephrine transporter, such as solriamfetol, produce a different wake-promoting effect than simply highly effective dopamine transporter inhibitors. This mediation through the inhibition of dopamine and norepinephrine reuptake is thought to be the mechanism by which solriamfetol produces its potent wake-promoting effect and improvement in subjective symptoms of excessive sleepiness, as well as maintaining its clinical effectiveness after several months of use.
Good, thank you, Rick. Both yourself and I were involved in the solriamfetol studies in narcolepsy, and here we see some of the data. On the left-hand side, we have the maintenance of wakefulness scores, looking at the latency, and this was with 3 different doses of solriamfetol, 75 milligrams, 150 and 300 milligrams compared with placebo. And you can see there is clearly a dose relationship with the effect on sleep latency. And the effect began really right at the beginning, right at the first week, and there were significant improvements in that sleep latency objectively. And that was held right through the 12 weeks of the study. So at the end of the study, you can see the 300 milligram dose of solriamfetol and the 150 milligram dose produced statistically significant improvements in that objective sleep latency. On the right-hand side, we see the Epworth Sleepiness Scale, that subjective scale, and you can see a very similar pattern here. Of course, down in this case is better because you're reducing the sleepiness subjectively. And again, you see the effect occurring quite quickly at that first week and maintained throughout the 12 weeks of the study. And for the 3 doses, the 75, the 150, and the 300 milligrams, there were statistically significant improvements compared with placebo at the end of the study. So solriamfetol improved sleepiness both objectively and subjectively. Now, Rick Malhotra also did a study on solriamfetol in sleep apnea. Can you give us a little bit more detail about this?
Sure, yeah. And before you move on, though, I will point out about that study that we did in narcolepsy. On the MWT, we saw a response in the first hour, and it was sustained across the entire day, which is really interesting with this particular molecule. It wasn't, you know, the afternoon, there was no afternoon dip in there. So this was the double-blind placebo-controlled trial. And of course, the FDA did not approve the 300 milligram dose. It only approved up to the 150 milligram dose. But this, this other study that Malhotra published, again, we talked earlier about tolerance and rebound and withdrawal. And what's neat about this study is that we have long-term data. I mean, we have effectively a year's worth of data looking at both patients with, if you look in the left upper side, the Epworth score in a 52 maintenance study. So these individuals were rolled over into a long-term maintenance trial. And with obstructive sleep apnea and narcolepsy, you can see the Epworth score is significantly improved in those individuals. If you go to figure B in these individuals, this was also a neat study to allow us to begin to look at rebound and withdrawal in these folks. So about 6 months out, they were randomized, blinded. So this was a group of narcolepsy patients and sleep apnea patients, and half of them were randomized to the placebo group. And as you can see at the baseline, you see that these are sleepy people. Their Epworth scores are abnormal. And then you look 6 months out, their Epworth scores, these are responders. The Epworth scores are normal. And then when you wean them, or not wean them, but you transition them into placebo, you can see the sleepiness gets worse. Interestingly, the Epworth score did not go above baseline, so we didn't see rebound, and there was really no evidence of withdrawal. The figure C looks at the patient global impression of change in this 52 maintenance of effect trial. And so you look at overall and obstructive sleep apnea and narcolepsy, look at the percentage of patients that show persistence through this 52 weeks. So again, showing an absence of tolerance in these individuals. And in figure D, the PGIC in the randomized withdrawal phase. So here we're asking the patients, what happened during this withdrawal period? Did they get worse or not? And then what you see is in the placebo group compared to the Solriamfetol group, there clearly is a biological signal there that shows that with the drug, these individuals are better able to maintain wakefulness. Long-term study, very useful study for us to think about in terms of, again, tolerance, rebound, and withdrawal.
So it's pretty clear from this data that solriamfetol is efficacious in both narcolepsy and sleep apnea, and over the long term. But how about safety, Rick? Tell us a bit about safety of solriamfetol.
Yeah, again, this is a centrally acting drug, so it's activating these awake circuits, and based particularly upon Schedule II stimulants. Yeah, we're worried about heart rate and blood pressure effect, but when you look at these individuals in terms of the effect on heart rate and blood pressure, there really wasn't a strong signal there. I know in the pivotal trial data where we had ambulatory blood pressure monitoring, there could have been a few outliers in terms of the effect, and we do want to monitor blood pressure, but that second bullet point there, at 8 weeks, there was no increase in the percentage of non-dippers. And as you well know, when you go to sleep and you wash out sympathetic tone, your heart rate and blood pressure drop, and there was no evidence, and there was no clinical evidence of significant increases in systolic, diastolic blood pressure, heart rate, or mean arterial pressure with this. In the first bullet, which I skipped over, in the 24 patients with narcolepsy 2 hours post-dose, it produced improvement in driving. So these and driving simulators, or actually in the car driving, lane drift was less. So obviously we're worried about fatigue-related accidents, and here was a signal that demonstrated safety from that perspective. And then again, unlike modafinil, armodafinil, and pitolisant, solriamfetol does not affect birth control. It's excreted in the kidneys. And so it does not have any effect on birth control. Therefore, we see much less drug-drug interaction with this particular molecule. And when it was studied for abuse, again, we worry about abuse and misuse of these drugs. When it was compared to phentermine at much higher dose, 8 times the dose, it really had no affinity for these connoisseurs of drugs in terms of liking. It was comparable to phentermine, and therefore the FDA scheduled this as a Schedule IV drug, not a Schedule II or a Schedule III drug. So what do you think, Michael? Any other comments about safety that you want to bring up? Did I leave something out?
No, I think you've covered it pretty well, Rick. The solriamfetol only became available last year, so it's a fairly new agent, and I'm sure a lot of our audience is just not that familiar with it. I mean, how do you think it fits into our armamentarium of treating patients with both narcolepsy and sleep apnea, along with other drugs that we have available? Where would you tend to use this?
Yeah, I think we're going to explore this some more later on, but for me, I have a lot of young females with narcolepsy who are on birth control, steroidal birth control. And so this is huge for that group. Because
I would agree. I think that, those younger females, the fact that a number of the drugs, and you've mentioned a couple of them there, the modafinils and pitolisant that affect the oral contraceptive agents, that's a pretty big concern for a lot of young women. So
Yeah,
it is one big advantage of solriamfetol.
Yeah, and I'm impressed with the sympathomimetic effect. So it seems to be much less, certainly compared to the Schedule 2 drugs. So when I have someone with sleep apnea who has hypertension, diabetes, and a BMI of 36, you know, this
Right.
this is encouraging. So
yeah, I think overall the safety profile does look a little bit better with solriamfetol compared with the others. You know, you don't have those allergic reactions, the potential for very severe rashes like Stevens-Johnson syndrome, etc.
I'm anxious
Would you
to see
use
our
this
clinical
as a
experience.
first line?
Go ahead, I'm sorry.
Would you use this as a first line drug? Would you start off with this, or would you sort of add this in after patients have been treated with other medications?
Yeah, you know, when I've used a lot of modafinil, armodafinil in the past and still do. But when I look at the effect size, remember you looked at that efficacy data on the double-blind placebo-controlled trial, and I see the effect size on the MWT and the Epworth score, and that impresses me. So I'm very comfortable using this as first-line therapy in patients with narcolepsy and obstructive sleep apnea. Of course, I haven't abandoned modafinil, armodafinil. I certainly use them as well, taking into account, again, efficacy. These patients are sleepy. I want to try to help them as much as I can.
I'm sure we could talk a lot more about solriamfetol, but time is against us, so we must move on. Yep. So let's go to another animation. Rick, can you tell us a little bit more about pitolisant, which is, again, another new therapy that's approved for excessive sleepiness, only in narcolepsy, but not in sleep apnea. Tell us a bit more about it.
Histamine is a wake-promoting neurotransmitter that helps to stabilize sleep and wakefulness and is modulated by orexin. Pitolisant is a highly selective histamine H3 receptor antagonist, inverse agonist, that works by increasing levels of histamine in the brain. Its main action is mediated at a presynaptic level through activation of histaminergic neurons in the brain, showing both the increase in histamine synthesis and release by inhibiting the H3 receptors in the presynaptic site. Histaminergic neurons are involved in a large variety of functions, including wakefulness, attention, and memory. Pitolisant promotes histamine release. Pitolisant also modulates the release of various neurotransmitters involved in wake promotion in the brain, such as dopamine, norepinephrine, and acetylcholine.
So, Michael, you know a lot about pitolisant. Share some of the efficacy data.
Okay, well, if we look at this study, this is a study over a 12-month period. So it's a long-term study with pitolisant. You know, again, pitolisant is FDA approved for treatment of sleepiness in narcolepsy, and this is looking at that subjective Epworth sleepiness scale. And you can see that there is improvement in the dark red graph here compared with control. And that persisted over the course of the 12 months of the study. So it shows again that this is an effective agent for sleepiness that can produce a persistent effect. And if we look at the efficacy in sleep apnea, now of course it's not FDA approved for sleep apnea, but there have been studies that have been done in sleep apnea. And I think the easiest way to follow this fairly complex illustration is to look at the p-values on the right-hand side, and you can see which ones are statistically significant. So the final Epworth sleepiness score in this study with sleep apnea was statistically significant with pitolisant. There's a lead sleep evaluation questionnaire. Probably most people are not that familiar with it, but this looks at nighttime sleep and the daytime consequences of it. And again, a higher score is better. So you can see that there's a significant improvement there in the global LSEQ score. And then in the clinical global impression score improvement, there was significant improvement at the end of the double-blind treatment period with pitolisant in sleep apnea. So if we look at the safety data, so, you know, again, those typical adverse events are relatively common with these alerting medications that improve sleepiness, nausea, insomnia, anxiety. But with pitolisant, one of the concerns is it does tend to prolong QT interval. That's something that people need to be cautious of, particularly if patients are taking other drugs, for example, clomipramine for other reasons, and or even for narcolepsy. Some people take clomipramine. So that increases QT interval in combination with pitolisant. That would be of concern. And as we've discussed already, it reduces the efficacy of hormonal contraceptives. It's metabolized in the liver, so will increase the metabolism of ethinyl estradiol. But overall, in a study of 303 patients with narcolepsy, it was pretty well tolerated and fairly safe medication, and has a lower abuse potential compared with some of the other drugs. And in fact, it's a non-scheduled drug for that particular reason, because it does have that good abuse potential rating. So let's move on and ask another question for our audience. This is one again that we showed earlier. So we'll have the pre and post results here. So which of the following is best suited for a 31-year-old patient with excessive sleepiness associated with narcolepsy who's currently taking oral contraceptives? Is it A, armodafinil, B, modafinil, C, pitolisant, D, solriamfetol, or E, you just don't know? Okay, so most people pick solriamfetol, which, as you know, it's the only one of these drugs that does not affect oral contraceptive agents, so certainly has that advantage. And it's interesting to see that there is quite a change from the earlier results compared with the current results. So delighted to see that people have picked up on that. Okay, Rick, why don't we move on to some of these more emerging therapies. You mentioned a bit about JZP-258 earlier. As you said, it's a low sodium formulation of oxybate. Well, how did it do in terms of the studies? How effective was it?
Yeah, this is a little bit complicated study, but when you look at the efficacy here, you could look at cataplexy. This was patients with narcolepsy type 1. You look at cataplexy and sleepiness, but this was a maintenance of effect trial. So the patients were transitioned to this JZP-258, which again is not sodium oxybate. It is still oxybate. So patients came into the trial and they were placed on this molecule, reached a steady state, and then they had a period where they were withdrawn for 2 weeks, blinded, some on placebo and some still maintained drug. And what you can see is the change in the Epworth score with this, and the ones who were on drug compared to the ones who were transitioned to placebo, actually the placebo group got more sleepy when you withdrew the drug. So this is valuable from, I mean, it's humane, really. You take some people with narcolepsy who are profoundly sleepy, and rather than double-blind placebo control for, 4 months of no drug, they were treated and then withdrawn for 2 weeks. So we see a signal there that these individuals are less sleepy if they stayed on the drug. And then the patients were also rolled over into a long-term study that looked at the drug for almost a year. So again, we did not see tolerance in those individuals. And also there was improvement in the cataplexy. Cataplexy was well controlled. You and I worry about when we take patients off certain drugs having rebound cataplexy. The cataplexy came back, but it didn't come back with a vengeance. So there was efficacy for the cataplexy as well. The side effect profile is really comparable to sodium oxybate. This is oxybate. It's just a different cation, 92% less sodium. And you can see the different cohorts that were enrolled. I mean, there were some people on sodium oxybate only, some on sodium oxybate plus other anticataplectics, some only on other anticataplectics, off-label SNRIs, tricyclics, or maybe even Pitolisant, and then others who were completely naive. And when you look at those groups, you can see a little bit of difference more in the individuals who were sodium oxybate naive. You see more side effects, but the side effect profile is really much like the oxybate profile. I mean, headache and nausea and dizziness, and we did see some rebound cataplexy in some of the individuals who are on anti-cataplectic therapy, particularly SNRIs. So you can see that as a side effect, decreased appetite, and some of the other ones. But it's very comparable to what we have seen in our experience with sodium oxybate.
Well, Rick, we've talked about a lot of medications in this presentation, and I'm sure for our audience, it's become a little bit complex, sort of knowing, well, which ones for which situation. We sorted out a few. So if we can go to the algorithm, this is one theoretical sort of treatment algorithm that one might consider. Of course, it doesn't have every option that's available because there's a lot of drugs, as we've talked about it. But for many patients with narcolepsy, and particularly those with NT1, but also patients with NT2, we would probably go to oxybate as the first line drug. Oxybate is, and particularly at the moment, we have sodium oxybate. Maybe in the near future, we'll have this new low sodium formulation available to us. But at the moment with Xyrem, it's the only drug that really treats all the features of narcolepsy. They're not only the disturbed sleep and the sleepiness and but the REM phenomena. But, as you're aware, it's not always effective 100% in all patients, and many patients need some additional medication. So what are you going to go to next? I mean, part of this is driven by insurance, of course, because not all, and particularly some of the newer medications, are not approved by some of the insurance companies. But, let's assume at the moment that, everything is available to you. Then maybe if you needed to add something in for sleepiness, you'd probably go to Solriamfetol. What do you think, Rick? Would that be your second choice in addition to sodium oxybate for a narcolepsy patient?
Yeah, I mean, the sodium oxybate is the only drug approved in the FDA at the moment to treat cataplexy. So if you've got an NT1 patient, I'm pretty quick to go ahead and start the sodium oxybate. I also know 80% of the patients on sodium oxybate are on stimulants. So I sort of do it at the same time. So if I have a young female on steroidal birth control who has type 1 narcolepsy, she's having cataplexy, I will go ahead and start her on Solriamfetol, and at the same time start the sodium oxybate. And as you know, it takes a while. I mean, it takes 2 to 4 weeks to begin to get improvement in the sleepiness and the cataplexy. So I think we have to take that into account.
Yeah, it's a very good point, because something that's not often discussed is when do you introduce these drugs? And as you say, it can take time for the Xyrem to have its effect, and for someone that's severely affected and they're concerned about driving, you probably want to start them off on something really quickly that's going to have an effect. And you mentioned earlier that Solriamfetol was seen to have an effect even within an hour in some patients after starting it. So, adding in a medication like Solriamfetol makes a lot of sense. But if the cataplexy isn't fully effective, what do you think about adding Pitolisant in with the Xyrem?
Now, that's an interesting question, because in Europe, Pitolisant is approved to treat the excessive sleepiness and also approved to treat cataplexy, but it's not approved in the U.S. Now, that doesn't mean that we can't treat the sleepiness and hope the cataplexy will improve. Pitolisant's interesting because, the half-life's about 20 hours and it takes 7 days to reach steady state. So again, it's a slower drug. And and you have to start out at 8.9 milligrams. You have these tiny little pills, 8.9 milligrams. In Europe, it's 10 milligrams. But 8.9 milligrams, you do that for a week, and then you go up to 17.8 milligrams, do that for a week, and then you go up to the 35.6 milligrams, and then reassess. So it's a slower compound, a slower molecule. Good news is it's not scheduled. The other good news is, especially based on the European experience, is Pitolisant's been used with lots of different medicines. I mean, it's been used with sodium oxybate, it's been used with modafinil,
Right.
and so it doesn't mean it's just one drug. I mean,
Yeah.
polypharmacy with pitolisant is actually not unusual, and
Yeah, it's a little confusing for people because, Pitolisant is only approved in the USA for sleepiness, but we
right,
know from the European studies that it is effective for cataplexy.
yeah,
And really, you don't have many other choices for cataplexy except for the traditional antidepressants, and
right.
Pitolisant's about the only other one. So if somebody is on sodium oxybate still having it, it's something you'd want to consider. Would you add pitolisant to help that cataplexy? Now,
Certainly,
of course,
I would agree with that. I mean, it's just um, it may, hopefully it will be effective. And when you think about the neurotransmitters, the release and the different areas that are being released, so it makes sense that we might
right.
ping the histamine receptors and ping
Yeah,
the dopamine and norepinephrine. So it kind of makes sense. And that when we have, particularly in NT1, where we have a deficiency of orexin and downstream, all of those neurotransmitters are down regulated,
right.
are not stimulated as much as they should be. It makes sense that we might pick out some of those receptor sites to try to enhance the well-being of our patients.
Unfortunately, not everybody's able to take sodium oxybate for various different reasons. And so then, if we've got a patient who has NT1 that has cataplexy, then what do you think about considering pitolisant, even though it's not approved for cataplexy, but again, it is the only other drug that treats both sleepiness and cataplexy.
Yeah, I would agree. I mean, it's all the patients are sleepy, so I'm treating the sleepiness, and based on the European literature, we can hope that cataplexy gets better. And again, as I said, we can always add another wake promoting medication, such as the Solriamfetol. And if the cataplexy continues, then what we know is obviously these serotonin and norepinephrine receptors inhibit the REM generator, so they will in turn help with the cataplexy. We've used those off-label for years, and it just so happens that venlafaxine is fairly potent in its effects, so it's been sort of our go-to medication to try to inhibit cataplexy.
Yeah, as you mentioned, though, for in many of the studies, people have found that they've needed to combine pitolisant with some other drug. So if there's still some sleepiness despite the pitolisant, I guess one would consider adding solriamfetol, and or if the cataplexy wasn't fully controlled with pitolisant, considering venlafaxine. You do need to be a little careful about pitolisant, adding it with other antidepressant medications, and may want to follow those patients a little more closely. But that combination, pitolisant plus venlafaxine, may be very effective for cataplexy.
Yeah, I think that's more worrisome with paroxetine, because pitolisant is metabolized, as you said, in the liver, primarily through the 2D6. And if you have someone who's a low 2D6 metabolizer, or if you use a drug that inhibits 2D6, such as paroxetine, then you may get higher pitolisant levels, primarily because it's metabolized through the 2D6 pathway. We really haven't mentioned much about modafinil or armodafinil. I certainly have not given up on those. I have many patients who are on either modafinil or armodafinil, and just you remember, modafinil has two isomers in it, the S and the R isomer, and then armodafinil is just the R isomer. So there's some difference in terms of PK exposure, but we certainly use those drugs. But again, metabolized through the liver, so it is a 3A4 inducer, and you have the issue with the birth control pills.
Right. Now, if you can't take sodium oxybate and you can't take pitolisant, where do you go then? I mean, certainly if you would use solriamfetol probably as your first line for excessive sleepiness. And then if you have to treat the cataplexy, then you would probably add in one of the norepinephrine reuptake inhibitors, again, such as venlafaxine.
Right.
So there are a lot of treatment options, and as you've mentioned, we may need to use modafinils in conjunction or as alternatives to some of these options. Okay, so I think we've come to the end of our program, and as you realize, the burden of excessive sleepiness is vast, encompasses reduced quality of life, impaired cognitive function, poor workplace performance, mood changes, and affects cortical functioning. And there are limitations with the long-time first-line therapy, such as the traditional stimulants in particular. And so there is a need for new therapies and drugs with different mechanisms of action. And that's what we're starting to see become available here. As we've talked about it, sodium oxybate is effective for all the main symptoms of narcolepsy and has really become a mainstay medication for the treatment of narcolepsy, particularly NT1 narcolepsy. And solriamfetol is relatively new, but it clearly improves sleepiness associated with narcolepsy and sleep apnea. And for many patients, it may be the only drug they need to control their sleepiness. But targeting histamine pathways is another alternative as well for patients. It's clearly been shown to be efficacious. So let's finish with another audience response question, one that we've had before. So now, how confident are you in developing treatment plans for patients with obstructive sleep apnea syndrome or narcolepsy that reduce the burden associated with excessive sleepiness? Do you feel now extremely confident, somewhat confident, or not at all confident? Please make a choice. Okay, well, I'm delighted to see number 4, how it's gone down dramatically so that patients, the audience is far more confident in their choices. And so very pleased to see that. Okay, let's have another question. How often do you consider mechanism of action when making treatment decisions for excessive sleepiness in narcolepsy or sleep apnea? A, never. B, 1 to 25% of time. C, 26 to 50. D, 51 to 75. Or E, nearly all the time, 76 to 100% of time. Okay, good. Significant change here. There's number 5, 76 to 100% of time is greatly increased. Well, I'm delighted to hear that because I think we've moved into this time of considering mechanism of action. And because these drugs are working through different receptor systems, it's important to consider that. So we've been reminded of the significant impact of excessive sleepiness on functioning and on the excessive sleepiness and functioning and the quality of life. And therefore, we need to implement effective therapy. So let me provide a few SMART goals from today's program. So identify the potential CNS pathophysiology of excessive sleepiness in narcolepsy and sleep apnea. Incorporate this into your practice. Effective treatments with novel mechanisms of action that can reduce the burden of excessive sleepiness in narcolepsy and sleep apnea, as well as reducing the risk for abuse. So consider that not only reducing the excessive sleepiness, but consider reducing the abuse potential, and also consider the adverse effect profile as well.
Yeah, Michael, I really like the SMART goals. I mean, this is the emphasis on the neurotransmitters and what's going wrong, and thinking about our medications, the pharmacokinetics of the medicines, how much exposure you have, which neurotransmitters are you hitting, and then interpreting how the patient responds. This is exciting to see the pre and post responses and the sensitivity to thinking about what's going on with these neurotransmitters. It's encouraging. So.
All right. So do you have some questions there, Rick?
I don't see any. I may not be able to see it as well as you can. All I've got is, because I couldn't see the poll results other than your report.
Oh, I see. Yeah. Okay.
You're in charge.
Okay, here we go. I think there we go. Now I've got the question. So here's, let's see the first question. How often do you encounter tolerance with armodafinil? Any thoughts on that, Rick?
Yeah, I do think we see some tolerance with armodafinil. I know we do have some long-term data, and well, not really long-term data, but we have some longer-term data on it. But I do think we see some tolerance in those individuals. I don't see withdrawal and rebound necessarily with it. At least that's my impression. Hadn't been well studied, quite frankly, but I think there are a percent of patients in whom we will see some tolerance.
Someone's asking about ADHD, and in these studies where we're looking at excessive sleepiness and sleep apnea and narcolepsy, wondering about were they being screened for ADHD? That's a sort of a difficult question because as you are aware, there's a great overlap in terms of symptoms between ADHD and narcolepsy. Many of our narcolepsy patients have been misdiagnosed as having ADHD. And many of them carry both diagnoses, and it's not clear, what the role of one versus the other is. So I would say that, virtually most patients that have significant sleepiness have some ADHD type symptoms, but I don't know that they're clearly everyone with some ADHD features is eliminated from these types of studies. What do you think, Rick?
Yeah, I think that's a good point. I've told many people this, my biggest referrer of narcolepsy is an ADD specialist. And people who are sleepy, as you pointed out early on, the cognitive effects of thinking and memory, reaction times and focus, automatic activity, which, short-term memory, people do things and they don't remember doing it. So many times they have ADD features, but it's because of the sleepiness. However, having said that, you could have both. And I know there's some literature out there that shows patients with narcolepsy may have a higher prevalence of ADD. I don't know how that's a tough group to study because they're sleepy. But I completely agree. Sleepy people have attention problems and oftentimes are misdiagnosed. When you make them less sleepy, their attention gets better.
Right. I have several questions that came up here about the elderly and the use of medications treating narcolepsy. And one of the questions was asking, behavioral versus pharmacotherapy. Would you go for behavioral therapy? And, I would just like to say that, elderly people can be extremely affected because of narcolepsy. I recall one elderly patient that came to me and I saw her for the first time. And she was in her early 80s, and she was just having continuous cataplexy in the office. I mean, she was just not treated. So I think whoever was treating her was thinking that maybe she was too old to take medications for narcolepsy, but she was severely impaired. The good thing is that most of these drugs have been studied in the elderly, and the elderly have tolerated them. Of course, you need to consider those adverse effects we talked about and the mechanism of action. But yeah, elderly people need treatment just as much as younger people. And in general, you can make dramatic differences to people's quality of life and reduction of sleepiness and improved cognition by the use of these medications. Any thoughts about that, Rick?
Yeah, I think, and that's one thing we really didn't talk much about behavioral therapy, but, narcolepsy patients are just like you and me. They stay up too late and they do things they shouldn't do. So I think, understanding circadian process, sleep-wake processes, the fact that your own neurotransmitters are doing different things at different times of the day and timing those with when you give the patient's medication will improve the efficacy of the medication. And then certainly, so respecting sleep, the best thing for sleepiness is sleep. So respecting the circadian process, timing of their medications, strategic naps, as you well know, particularly narcolepsy patients are really good at taking strategic naps. In fact, I saw a fellow the other day. This is amazing. I mean, he would sleep all night, had a really good sleep hygiene, but he basically would take 3 naps a day. He was in the military, interestingly. He would take 3 naps a day, and then after the naps, he did all right for a few hours. Then he'd take another nap. Then he'd do all right for a few hours and take another. And now he's getting ready to go out into a new job and he can't take a nap in the daytime. So it's amazing he could get by taking those strategic naps. But and that can be very beneficial, as you well know.
Sure. Now, there's a question here about the sleep apnea patients and the treatment with these medications. And, you know, I think one does have to be very careful about the use of alerting medications in sleep apnea patients. You know, in the past, of course, we only had the traditional stimulants available to us. But I think now with the options we have available, that they certainly are not first-line treatment at all, and maybe shouldn't even be considered because they do have adverse cardiovascular effects, which you just do not want in your sleep apnea patients. So you're going to go to a drug that is not going to have any effect on cardiovascular issues, because that's one of the major concerns in sleep apnea because of the high incidence of cardiac arrhythmias. So, you know, you would want to be a little careful and be about the QT interval situation. So you would want to see if a patient has a normal EKG and doesn't have any QTC interval prolongation or is not on other drugs doing it. So you'd be considering that. What do you think, Rick, about drugs for the sleep apnea patients and the risks of treating them?
Yeah, I think and obviously they have comorbidities, particularly cardiovascular comorbidities. So we want to make sure that they're in a stable state. You know, their blood pressure is well controlled, and if they do have any kind of arrhythmias, that those are adequately controlled. But certainly modafinil, armodafinil, and solriamfetol are very reasonable choices. They are approved by the FDA, and we don't see that much heart rate and blood pressure effect. It's still important for us to monitor because there could be outliers and unusual sensitivity to the drug. So we want to follow them along and make sure that their heart rate and blood pressure do okay, and obviously monitor for other CNS side effects in terms of anxiety or headaches or dizziness or this sort of thing. But these drugs are now available. And I think the point I mentioned cohorts earlier, the prevalence of excessive sleepiness in adequately treated patients is fairly high. And I mean, it's north of 10%. It may be as high as 20%, really. But that's even in patients that you have them perfect. I mean, they're using the CPAP 7+ hours and their AHIs are less than 5, and they're still sleepy. And because they're sleepy, they are at risk. I mean, one, the quality of life, but also fatigue-related accidents. So I personally think they should be treated. What we have to recognize is that the medications are treating the sleepiness. They're not treating the sleep apnea. So it's important for us to make sure that they're adequately treated, and we know what's going on. We've ruled out other sleep disorders that are going on. We make sure that they don't have narcolepsy, because we know 25% of people with narcolepsy have sleep apnea or develop it later on. So we want to make sure they don't have narcolepsy, that this is our sort of a pure obstructive sleep apnea patient, and now we put them on therapy. And I think I would encourage everyone to look at the pivotal trial data on the solriamfetol, because this was clever in that and I was actually one of the investigators, as was you. We had a cohort in there and we tried our best to get them to use CPAP, and they would not do it, or some sort of therapy, or oral appliance or whatever. But we had a cohort that did not use their CPAP, and they were still sleepy. And solriamfetol was studied in that group. And so efficacy measurements, still effective. And safety, the same safety profile in this particular cohort. I'm not saying that we use solriamfetol alone in patients with untreated sleep apnea. We need to treat them. But the point is, I think that shows the efficacy and the safety of that particular drug. And so these sleepy people need to be treated.
Yeah. There are quite a few questions here regarding stimulants, and what would you prefer one stimulant? In particular, they're saying methylphenidate versus amphetamines or alternatives, and do they have adverse effects on nighttime sleep? And would you combine them with other wake-promoting medications? But let me just say that I think that we're really moving into a time where stimulants are really third line therapy. I mean, we can't not use them at all. We certainly have patients who have used them for many, many years and do well on them. But I think that if we have the option of not using the traditional stimulants, we're better not to use them because of the reasons that we mentioned earlier about, abuse potential with these drugs, about cardiovascular effects. I think there are psychological effects associated with them. So if we can move away from the traditional stimulants, all the better. I mean, most of these medications will affect nighttime sleep, and certainly methylphenidate and amphetamines will do that, but so will a lot of the other wake-promoting medications. So one has to always look at the issue of nighttime sleep. You don't want to treat their daytime sleepiness and make their sleep at night much worse. And as for combining medications with the newer agents, I mean, sometimes we actually do that. What we do is that we may have a patient on a background level of medication. For example, one of the modafinils, which covers them during the waking part of the day, but in the late afternoon, they may find that it tends to wear off, and you don't want them taking a longer acting agent. So sometimes we might use a short acting traditional stimulant medication to cover them for 3 or 4 hours in the evening time. So we sometimes do that, but I think that that type of use is getting a little bit less. We can manipulate the newer drugs that we have so that we can get a good control over the waking portion of the day. Any thoughts about that, Rick?
Yeah, I mean, we worry about tolerance. All of us have used amphetamines and methylphenidate, and the patients are like, whoa, wow, I can feel this quickly and it makes me feel good. And then come back a month later and they want more and they want more and they want more. And then we start getting into potentially toxic ranges. So, and we do know high dose, particularly high dose amphetamines may actually be neurotoxic as it's metabolized through the monoamine oxidase pathway. So I tend to opt to go with a methylphenidate. If I can, then obviously move to the amphetamines if that doesn't work. But it's really interesting because, we think of modafinil, and our modafinil is working primarily on dopamine, and Solriamfetol, dopamine and norepinephrine. It's theoretically possible. We don't have data, but it's theoretically possible if we affect the transporter, maybe we would keep the dopamine and even norepinephrine at the receptor site longer. And many of my patients have big problems during the circadian lull, right after lunch. And so I might allow them to use a very low dose of an immediate release formulation of a Schedule II drug if that's, what we need to do. And without any data, just clinical experience, but based on the neuropharmacology, I've been successful at using fairly low doses of immediate release Schedule II drugs to try to help get past that siesta time. So they either take a nap or not all of them, certain ones, but if you're already sleepy and you hit the circadian lull, then some of those patients really complain about their ability to get work done in the afternoon or even on their commute home, depending on what time they get through.
Right. Someone is asking about the JZP drug, the 258.
Right.
And wondering whether it's a better option for patients with cardiac disease. And as you mentioned, Rick, it does have 92% less sodium than sodium oxybate, and so there's less sodium load. And we know that sodium load is a concern for a number of cardiovascular issues and metabolic issues. And so the overall thought is that, going forward, that having less sodium is probably an advantage. And I think there's more data coming out all the time about the detrimental effects of extra salt or extra sodium in cardiovascular patients. But the question is really, what do we know about the actual data? And unfortunately, we're pretty light on data because the studies that were done, of course, the focus was on the efficacy and the safety profile of it. The safety profile looks good with the low sodium formulation of oxybate and is not too dissimilar to that of regular sodium oxybate. But specifically looking at cardiometabolic issues hasn't really been studied in such detail as yet. Have any thoughts about that, Rick?
Yeah, I thought it was interesting. The sodium oxybate group was transitioned almost to the same dose as this particular molecule. So it's the oxybate. There might have been some small tweaks, but pretty much close to the same dose. You know, blood pressure was not a signal that was followed closely, but the good news is that there were no blood pressure signals in terms of increase in blood pressure with this particular molecule. So, and then the other is, you know, it's when you're on therapeutic doses of sodium oxybate, you're getting, you know, over a gram, 1.6 grams, and that's beginning to approach what you should be eating every day, if you know what I mean. So, and of course, the effect of a high salt diet is a long-term effect. So we're not likely to see a big change in a study that's, you know, primarily 12 weeks or of course we studied these patients long-term open label, but we're not likely to see a huge signal there unless you are really honing in on looking at it. We didn't do ambulatory blood pressure monitoring and things of that nature, but intuitively it's less salt exposure, which I think is a good thing. So 92% less.
All right. So we have a question here about solriamfetol, and you know, it has, as we mentioned, it has norepinephrine reuptake inhibition effects, and people are asking, you know, would it have antidepressant effects? And what do you think about that? You know, we know that patients with narcolepsy have fairly high rates of depression. I mean, could this drug have some benefit on depression as well? Or do we have any data at all, Rick, on antidepressant effect of solriamfetol?
No, I don't think we have any on the antidepressant effects. You know, there's norepinephrine and there's norepinephrine, so it kind of depends on where it is in the brain. And we think of the solriamfetol as really, you know, more in the wakefulness promoting areas, but there's really no data on depression. Now, what we do know is that when patients are less sleepy, their coping skills are better, and we can see improvement in terms of mood, but it's not considered an antidepressant effect. So we saw quality of life improvement. We saw workplace performance improvement. So there were some measurements in terms of these quality of life measures that showed improvement, but not specifically oriented toward a depressed patient.
Yeah. Someone was asking about cataplexy, and I think that's important. I mean, we've talked a lot about these medications and patients with narcolepsy, but if you don't recognize cataplexy, you may not recognize that they have narcolepsy. So let's just talk a little bit about cataplexy. You know, the definition, which the question was specifically about, is that it's an emotionally induced muscle weakness. So that when somebody gets emotional, they will tend to get some weakness. And traditionally, we've tended to emphasize the worst cases where people will laugh or get very angry and they'll fall to the ground because they just lose muscle tone in their legs. But we recognize that there is a whole range and spectrum of severity of cataplexy, and even pretty mild, what seems mild compared with falling to the ground, cataplexy can be disabling for patients. And so it may be something relatively small, and it's something that physicians can pick up in their office if they're looking at a patient who has narcolepsy that has a little bit of emotion. They may see the head drooping a little bit, the face flattening. They may see the voice or hear the voice starting to quiver a little bit and slur, and that may be about the only manifestation of cataplexy. The patient, of course, would be sitting down, and so you're not going to see them fall to the ground with this, but just looking at the head and the neck, you very often can diagnose fairly subtle cataplexy in some patients, and that can be helpful for the diagnosis. But in general, unless somebody has very profound severe cataplexy with a good history of emotion causing them to fall to the ground, it can be really quite difficult. And it's something you have to really re-explore a number of times with your patients. You can't ask them once, do you get emotional and get weak? You've got to, every time you see them, come back and say, look, have you noticed anything different since we last spoke in terms of your response to any emotional situation? Not uncommon, patients will deny cataplexy initially, and then when they come back several weeks later, say something like, well, you know, I've been thinking and paying attention to what you mentioned, and I do notice that whenever I get emotional, I get this sort of drained feeling, and I, you know, am much more comfortable if I can find a chair and sit down, or just have to wait a few seconds, and then this feeling goes away. And that may be, you know, the features of the cataplexy. You got any particular tips regarding cataplexy, Rick?
Yeah, no, I think you were spot on. And the interesting thing is it's short. I mean, it's typically less than 2 minutes, sometimes even shorter than that. And if the patients, you know, block their emotion, it goes away. And they quickly learn that intuitively without really knowing what it is. They just recognize that they're melting, and, you know, they tell a funny joke and they feel briefly unstable and the knees buckling, or they have trouble getting the words out, or they drop things, and they'll block the emotion. And they learn that very, very quickly over time. But I'm going to seize upon this opportunity to go back to our animation, which we didn't emphasize probably enough, is that certainly in type 1 narcolepsy, these individuals are orexin deficient. And when they're orexin deficient, then the downstream stimulation of all those neurotransmitters, dopamine, norepinephrine, acetylcholine, and histamine and serotonin, all those are downregulated because of the deficiency of the orexin. And the awake circuits inhibit, not only inhibit or stimulate wakefulness, but inhibit sleep, and it inhibits dreaming. And so the narcolepsy patients tend to have REM dissociative symptoms. So, you know, Michael, you and I've talked before about the vivid dreams. They dream quickly, and that's why we use the multiple sleep latency tests and 2 SORIAMs, our 15-minute REM latency on the PSG, because the REM generator is disinhibited, and they have these dissociative REM symptoms. So vivid dreams and sleep paralysis, or hypnopompic or hypnagogic hallucinations. And of course, cataplexy represents a REM dissociative symptom that occurs in the awake state in these individuals. So when you go back to that animation, it begins to make sense in terms of how we approach these patients therapeutically. And like you, it's amazing. So many of the patients, I ask them about it, and sometimes I'm in a hurry and I say, do you have episodes of muscle weakness associated with strong emotions such as laughter? And they look at me like, what? You know, so you do have to ask them. Every sleepy patient in your clinic, I think it's fair to ask about cataplexy. And then the other thing is, as you pointed out, as you follow patients along, continue to ask them about it, because they may develop the sleepiness and then the cataplexy may develop later on. And I've had that happen to me and some of my patients. And as you said, then sometimes they learn, they recognize that, wow, I didn't know that was cataplexy. Yes, it is cataplexy.
Yeah, a question just came in. Somebody was asking about pseudo seizures and said, is cataplexy pseudo seizures? Well, I think they're quite different. In pseudo seizures, the patients that look as though they're having a seizure or epilepsy, and very often it is produced by psychological factors, but it's quite different to cataplexy. When a patient has a cataplectic episode, you know, one of the things that you can do is, if a patient actually falls to the ground and they look as though they're unconscious, you ask them to remember 3 words and give them 3 words. And although they're not able to respond and they're on the ground, once a cataplectic episode's gone, they can get up and they can repeat those 3 words, and because they're aware of everything that's going on around them, they're not unaware of it. And of course, that's one of the big differences from seizures, absence seizures, where people are not aware of what's happening at that particular time. So cataplexy is quite different from pseudo seizures.
Well, I have to say, you know, I had a patient who was on a tricyclic as part of one of the trials a long time ago, and he withdrew from the tricyclic. This was a long time ago. And he had terrible rebound cataplexy. And he came into my office and he knew he was going to have cataplexy, and he was trying to block it. And so he sort of oscillated in and out, almost like status cataplecticus. And so he would have these little myoclonic twitches, and then they go away and then happen again. So I swear it looked like a seizure. But as you said, these folks are wide awake. They are aware of what's going on in the environment.
Yeah. Well, unfortunately, I think we've run out of time, and it's a pity because there are a lot of good questions here that are in front of me, and I wish we had time to be able to answer them, but I'm afraid time just doesn't permit us. So I would like to thank Richard for being a part of this presentation this evening. I'm grateful for his knowledge and experience in terms of sleep apnea and narcolepsy, and it's been a great contribution. Also like to thank CME Outfitters for producing this program, and I hope it's been helpful for you, the audience. I really thank you for joining us for this presentation. I've enjoyed it, and I'm sure Rick has as well. Mm-hmm. And also remember, don't forget to complete your evaluation so that you can get those credits. I think if you've listened to us through the course of this, you deserve the credits. So please fill out the evaluation. And once again, thank you very much for joining us this evening.
Yeah, thank you, Michael.
Thank you, Rick.